Good afternoon, everyone. Thank you for joining us for today's webinar, Alcohol Use Disorders and Liver Disease, Improving Diagnosis, Treatment, and Outcomes. During our presentation today, audio and visual capabilities will be turned off for attendees to limit distractions. We do encourage you to ask questions of our presenter. Please submit your questions using the Q&A function on the Zoom toolbar at the bottom of your screen. Click on Q&A, type your question, and hit send. We'll address these questions as time permits during the Q&A portion at the end of the presentation. We are offering CME, Social Work CE, and McBAP credits for today's webinar. We'll have a slide up with information about obtaining these credits during the Q&A portion of the webinar. We will also email the continuing education credit information after the webinar today. My name is Katrina Hernandez, and I'm an engagement specialist with OPEN. The Overdose Prevention Engagement Network, OPEN, is a diverse team dedicated to improving lives and reducing harms of substance use. By engaging with individuals, communities, and organizations, we share education and resources to strengthen person-centered prevention, treatment, and recovery. With an overarching goal of developing transformative evidence-based solutions to reduce harm and stigma surrounding substance use, we work to support healthcare providers and communities in understanding and addressing substance use disorders at every level. We offer a variety of evidence-based services and resources. We offer on-call consultation services to connect prescribers to our addiction medicine experts who provide guidance for managing patients who have substance use disorders or complex pain and can answer both individual treatment and technical assistance questions. We offer expert-led education and training sessions. All of our webinars offer free CME, CEU, and McBAP credits, and for prescribers, all our credits also qualify for the DEA required SUD training. We provide MOUD training for physicians, and this year we are incentivizing primary care providers with $250 to complete one of our MOU trainings to encourage confidence and willingness to help expand access to MOUD treatment. To prevent new persistent opioid use, OPEN established and continues to update evidence-based opioid prescribing and counseling recommendations. These recommendations are based on patient-reported outcomes after various acute care episodes and provide information to inform opioid prescribing. You can access more information about all these services more directly using these QR codes or visiting our website. OPEN also provides tangible tools to reduce harms of opioid and substance use, and our hope is to disseminate resources to places that need it most. We encourage you to partner with us and apply for our programs. We offer a free library of evidence-based printable education materials for both patients and providers. Patient education materials can be co-branded for free and are available in English, Spanish, and Arabic. Provider education supports best practice implementation for primary care, acute care, obstetrics, pediatrics, and dentistry. We provide safe medication storage and disposal options. We assist groups all across the state in hosting local medication take-back events. We fund implementation of permanent medication disposal boxes for qualifying applicants. And we provide charcoal disposal bags and medication lock bottles for healthcare and community distribution. For overdose rescue support, we fund implementation of naloxone vending machines and distribution boxes, and we offer naloxone administration trainings. These trainings are offered as live, virtual, or free online training courses. No planners, faculty, or others in control of content, either individually or as a group, have relevant financial relationships with ineligible companies. Our presenter today is Dr. Poni Perumalswamy, and she is an associate professor of medicine at University of Michigan and the Ann Arbor VA healthcare system and health services researcher focused on improving access to care for patients with liver disease. Her research focuses on the development of clinical and behavioral healthcare models to identify and address system-level barriers to viral hepatitis care with underserved and vulnerable communities. In 2020, Dr. Perumalswamy joined the steering committee of the University of Michigan's Department of Health and Human Services Hepatitis C Virus Elimination Plan, which informs policy and practice to mitigate the spread of viral hepatitis. She also works with OPEN on an outreach and training initiatives aimed at increasing hepatitis C screening and treatment by primary care providers in rural areas of the state. And with that, I will turn it over to you.
Okay. All right. Thank you. So I'm going to be talking about alcohol use disorder in the context of liver disease. And improving diagnosis, treatment, and outcomes. And so to that end, I don't have any relevant financial disclosure. I will be discussing off-label medications for alcohol use disorder treatment. So we'll start with a case. This is a 38-year-old Hispanic woman with a history of metabolic dysfunction, associated liver disease. So she's been told that she has fatty liver due to cardiometabolic risk factors, and she's actually undergoing bariatric surgery. After a period of abstinence from alcohol, the patient is seen in the emergency department and then admitted. And she's separated from her partner of several years and is struggling through a divorce. She resumes alcohol consumption and presents with new onset jaundice. So her labs are shown here. Her total bilirubin is 6, her AST is 145, her ALT is 50, her alkaline phosphatase is 210, and her prothrombin time is normal. She does have an elevated white cell count of 25,000. Her platelets are a little bit low at 99,000. So you diagnose her with severe alcohol-associated hepatitis, and she's treated with steroids, and she's scheduled to see you and follow up in the liver clinic next week. So this is a good backdrop for the topic of discussion today. We know that globally, there's over 2.6 million deaths annually related to harmful alcohol use. And here in the United States, based on the latest data from 2024 National Survey of Drug User Health, close to 30 million people in the United States, age 12 or older, have a diagnosis of an alcohol use disorder. So it's really among the most common disordered substance uses that we see in the United States. And I guess the latest trends are suggesting that we might be actually starting to see somewhat of a downward trend over the last couple of years in terms of the number of individuals, but this still represents a very large portion of our population, about 10%. So 1 in 10 adults, over the age really of 12 have a diagnosis of alcohol use disorder. And we know that 50% of the risk of alcohol use disorder is genetic, it's inherited, and there is a high association with mental health disorders, which can increase your risk of alcohol use disorder. Furthermore, we know that early life experiences, including trauma in adult life, increases the risk of alcohol use disorder. And so ready availability of alcohol at low cost and widespread outlets are also additional important risk factors that at the policy level, the World Health Organization, and at various country level, national policy level, and even state level, there's some work to think about how do we impact the availability of low-cost alcohol to try to curb what we're seeing in the most vulnerable patients. Now, before we really launch into how we get to diagnosis and getting people engaged in care, we do know that there are a lot of barriers to and strategies for alcohol-related care. So care tends to be siloed, right? When we talk about somebody who gets diagnosed with liver disease and they have a substance use disorder, we often have to have patients go see all of these providers or seek care kind of separately for these different kind of states that commingle. And this is where integrated care and systems that can offer more things at the point of the patient can be helpful. Stigma still remains a major barrier to engagement in care, seeking care, and lack of motivation to change. Lack of insight can also contribute. There's structural barriers, and I should say that the stigma is not just at the patient level, but it's at the provider level and the system level. Along with other structural barriers and isolation, and then also struggling with an untrained workforce. Now, we know that AUD treatment is effective, but that uptake is low. So this is data in the Veterans Health Administration and looks at really what was going on in the year prior to COVID and then after COVID, and we saw all of these drops. So it's really, less than 1 in 10 adults with an alcohol use disorder in the last year received treatment in the VA system, and AUD treatment certainly dropped as a result of COVID and all the disruptions in care and increased over time, but after the end of the first year hadn't quite gotten back up to where it was before. And we know that we've had, as a result of, the COVID-19 pandemic, certainly expansion of telehealth, which has really assisted in our delivery of just healthcare across different disorders, but including substance use disorders. And here we were looking at the impact of telehealth and the delivery of alcohol use disorder treatment. And we do see that a lot of patients, over 50% in that first year after COVID, utilized some form of telehealth. 38% had a telephone visit, but no video visit. But still, there's still a group of patients who aren't able to leverage these tools, and in which in-person care is still super important. So all of this is to say that what we found was that telehealth did allow us to increase our treatment access and reach, but it wasn't one size fits all. So we're really here to talk about the connection between alcohol and liver disease and why that's so important. So we know that alcohol-related liver disease is a health crisis. When we think about why patients die from an alcohol-related reason, 60% of it is because of alcohol-related liver disease out of all of the alcohol mortality that we see. So it's the main reason why people die, unfortunately, from an alcohol-related reason. And what we saw over certainly the COVID-19 pandemic was that there were increases by 25% in alcohol-related deaths, and most of these deaths were in alcohol-related liver disease. And what we know furthermore here is that I think this came up in one of the pre-questions, but death rates from alcohol-related cirrhosis overtook all non-alcohol drivers for cirrhosis. And that overtake kind of actually happened many years ago, back in the 2006 to 2007 timeframe. So you can see here on the right, the red squares represent alcohol-related cirrhosis. And you can see the green circles represent all other non-alcohol causes for cirrhosis, and that there was this overtake of alcohol-related mortality from cirrhosis. And where unfortunately we've seen the biggest increases have been in young adults under the age of 45, in women, and in certain minority groups. Oops. So all of this is to say it's an important and continues to be a growing problem that we see from the health kind of system standpoint and in the health of our populations. And so alcohol-related cirrhosis is the main driver for cirrhosis and death from cirrhosis that we're seeing, unfortunately. Now, alcohol-related liver disease is a spectrum of disease. In an early stage, binge drinking or heavy drinking within a matter of hours to days can, in 90% of people, develop the earliest manifestation of just fat or steatosis. But that'll be largely reversible as long as the alcohol is not continued in that very high intake. Unfortunately, if it is continued in that high intake, then about a third of patients go on to develop inflammation with that fat. And over time, typically decades, patients can develop cirrhosis, about one in five patients. Now, we do also know that the progression along the spectrum is largely and primarily driven by the dose and duration of alcohol. About a third of patients can develop, like they did in this case, where they have an acute form of alcohol related liver disease, where they present very sick with jaundice and signs of portal hypertension, so ascites, encephalopathy, and oftentimes are really sick and present to the hospital. And among these patients, we unfortunately know that 70% go on to develop cirrhosis after this first alcohol-associated hepatitis. And 1 out of 4 patients have returned to alcohol use, which is a predictor for dying from liver disease. And so we do know that there are some identified and not yet identified factors that also can modify somebody's progression along the spectrum of disease. Things like nutrition and diet. So if you already have coexisting cardiometabolic factors, right, non-alcohol fatty liver drivers, that could influence outcomes. History of bariatric surgery is considered a risk factor for alcohol-related liver disease, older age, as well as some other factors you see here. Now, the terminology has somewhat evolved. When we think about fatty liver disease and causes for fatty liver disease, we have what we call alcohol-related liver disease on the right. So that's ALD, alcohol-related liver disease. And that's, again, primarily driven by thresholds of alcohol that we have defined in the field. of more than 50 to 60 grams of alcohol per day. If you're a woman or a man, those thresholds are women slash men, and or over a week of 350 or 420 grams in women and men, respectively, per week. On the left, you see something called MASLD. MASLD is metabolic dysfunction associated steatotic liver disease. That's what we used to call non-alcohol fatty liver disease. That is fat in the liver that's not driven by alcohol. It's primarily driven by cardiometabolic risk factors of type 2 diabetes or obesity, hyperlipidemia, hypertension, other what we call cardiometabolic risks. But the new thing in the last 2 years has been defining a group in between of what we call metabolic alcohol-related liver disease. So these are patients who are drinking a significant amount of alcohol that makes them not quite just in the pure MASLD category, but under a threshold that would meet the alcohol-related liver disease. And why this is important is that people don't live in the buckets we sometimes define these disease entities in. And we know that alcohol use is common across patients in steatotic liver disease, or SLD. And what we know is that alcohol is the thing that gets us into trouble the fastest across the spectrum. So in patients with alcohol-related liver disease, they have the shortest overall, the lowest overall survival, the shortest time to liver decompensation. If you're in that metabolic ALD hybrid condition, you're kind of right behind alcohol-related liver disease in terms of overall survival and time to decompensation. And then the MASLD or non-alcohol folks tend to have a better prognosis with better overall survival and higher times to decompensation. Now, what we know is that metabolic cofactors are increasingly relevant for alcohol-related liver disease, as I just said. From data from NHANES, we know that alcohol-related liver disease is present in about 0.7% of the United States adult population. MASLD, on the other hand, or non-alcohol fatty liver, is present in about a third of the U.S. population. A third of U.S. adults have some fatty liver. And of that, the majority is going to still be MASLD, okay? But then you can see this metabolic alcohol liver disease category is this hybrid category, and that's 3 times as common as the alcohol liver disease category of patients that we see. And 99% of patients with alcohol-related liver disease now have one or more metabolic risk factor. So what we know is that when you stack the metabolic risk factors up, even in patients who don't drink what we would say is an unhealthy amount, they have an increased fibrosis risk. And there is a dose-dependent increase in the prevalence of significant fibrosis observed between the number of cardiometabolic risk factors and the numbers of drinks per week. And that approaches a patient who's got metabolic alcohol liver disease in terms of fibrosis risk. So all of this is to say, you're going to hear about this more from a patient perspective. You're going to see it more from the health provider kind of standpoint. And it's important to know what this metabolic alcohol liver disease entity is, because it's actually way more common than alcohol-related liver disease and also can be associated with significant risks. So now all of this is to say is that treatment can reduce alcohol-related liver disease and the incidence of it and improve outcomes. So this was a retrospective study by folks at MGH, where they looked back in their whole health system going back to the 1970s. And they followed patients who had a diagnosis of alcohol use disorder who received treatment for alcohol use disorder. So if they received the medications listed in this table, and then they followed them forward and they said, how many of these patients go on to develop alcohol-related liver disease? And patients who received treatment were less likely to develop alcohol-related liver disease. What we also know, based on a study by Sherry Rogel and colleagues in the VA, is that starting patients who we identify with alcohol use disorder and cirrhosis on treatment reduces, this is treatment for alcohol use disorder. So those without treatment have higher rates of new liver decompensation, higher rates of death within 6 months, and higher rate of long-term mortality. And then finally, we know in patients who come into the hospital, for example, with alcohol-associated hepatitis, if we get them engaged into treatment within 30 days of discharge, they're more likely to survive, and they're less likely to get readmitted. So In order for us to understand who is at risk, it really begins by us thinking about how do we make the diagnosis of alcohol use disorder. And to get to that answer, we have to start by asking questions around alcohol use. In clinical practice, there's lots of ways we can talk to patients about alcohol. And they don't always get us to being able to quantify the amount of alcohol. And that's where this whole paradigm of screening, brief intervention, and referral to treatment came about. And this is an evidence-based model to try to, for alcohol and other substances, quickly screen patients to identify patients who might be at higher risk for a substance use disorder, develop a brief intervention to get patients to create a change plan, and then refer patients to treatment if they don't reduce or stop drinking. And so it can detect unhealthy alcohol use early, and it can actually help us detect alcohol use disorder early and show it is advocated for in terms of being used within health systems and practices. So the U.S. Preventative Services Task Force actually gives screening for unhealthy alcohol use in primary care settings for all adults, including pregnant persons with each pregnancy, a grade B recommendation. But the screening should also be coupled with a brief counseling intervention, what we call a brief intervention. The most accurate way for us to screen patients in a variety of settings, but particularly in practices, is using the very brief, less than 5 minute, 3 item audit C, which is an abbreviated version of the World Health Organization's 10 item alcohol use disorder identification test, the audit. And these 3 questions, as you can see on the right, get at how often do you drink, how much do you drink, and how often is there binge drinking? And this test is used globally, and it's validated, and it has high degree of accuracy. When a patient has a positive screen, right, a score of usually 5 or higher on a scale of 0 to 12, then that patient should be evaluated for alcohol use disorder. I think the biggest challenge we have is that we work in health systems, or maybe not even in health systems, where screening doesn't occur, but there are opportunities for them to occur. And many people with unhealthy alcohol use are not engaged in care for a variety of reasons. And so while we can talk about implementing these in like systems and in practices, there are a lot of spaces in which we see populations of patients in which we're not able to detect patients with unhealthy alcohol use. If you have a positive screen, I mentioned the next thing we need to do is actually diagnose them with alcohol use disorder, evaluate them. And this is classically done by a behavioral health provider doing an interview. And the definition of alcohol use disorder is a problematic pattern of alcohol use leading to clinically significant impairment or distress as manifested by at least 2 of the following 11 symptoms occurring within a 12-month period. So the 12 symptoms are on the right. And you can see, generally speaking, they map to impaired control, physical dependence, social problems, and risky use. And if you have 2 or 3 of these symptoms, that's what we would consider mild alcohol use disorder. If you have 4 to 5, it's moderate, and severe if it's 6 or higher. This is how, again, we would typically make a diagnosis. Now, we also know that in a patient who has a positive audit C screen, if you perform then the full 10-item audit, scores of 8 and higher can map to mild to moderate to severe alcohol use disorder. And organizations such as RAND have actually developed and validated a checklist approach to try to get more types of providers involved in the diagnosis of alcohol use disorder. In some places within the VA, for example, the Veterans Health Administration, that checklist is used as a first pass to then get them to a behavioral health provider to help make a diagnosis sooner. Now, there are many reasons why factors that drive inaccurate reporting of alcohol. So even when we use these screening instruments like the Audit C, there are both conscious and unconscious reasons that can play into why we don't get a good assessment of alcohol or an accurate assessment of alcohol use. So it starts with using validated assessments. So if I just ask a patient, how much do you drink? It's a very open-ended question. I might get a variety of responses like a few times a week, and then quantifying that into something that maps to problematic alcohol use can be very challenging. There are conscious reasons also that patients don't always feel comfortable reporting accurately how much they're drinking because they feel stigmatized or that they will be stigmatized and treated differently based on how they reported. Ineligibility for liver transplant, for example, is kind of one example. If you're honest about the amount you use, that might be used against you. And then there are unconscious reasons. Here in the United States, we define a standard alcohol beverage as containing 14 grams of alcohol. But we know that alcohol comes in different sizes and different proofs. And so it doesn't always map to what we think as what a patient might report as one drink might not always map to 14 grams of alcohol, right? Based on the proof or the size of the drink. And to make it even more confusing, across the globe, we have lack of country-specific standardization on this issue. So we are living now, though, in an era of direct alcohol biomarkers to help us aid to objectively identify alcohol use. So we used to use indirect biomarkers like an elevated MCV, a mean corpuscular volume of the blood cell, raised ALT or AST liver enzyme, but these don't directly measure alcohol in any way. But we do now have these other tests that we are leveraging more and more that directly do measure alcohol for us to try to corroborate and get additional information about whether or not we think alcohol could be part of the presentation of patient. And the different tests vary in terms of the amount of time, detection time. So, but blood alcohol level typically goes back up to 60 to 70 hours. The urine ethyl glucuronide or sulfate tests go back 3 to 5 days. Serum phosphatidylethanol, though, now has kind of, some people call it like the hemoglobin A1C of alcohol-related liver disease, in that it goes back 3 to 4 weeks in terms of its detection time. And the best practices we talk about is to use them, but we always talk up to patients about using them. They're not meant to be used to catch and punish patients, but really to say, hey, I want to be able to monitor this as we go forward. And we're talking about treatment for alcohol use disorder, so that if you are negative and then you become positive or it's still positive, then maybe I need to reach out to you sooner to talk about whether or not the treatment we just discussed is working or where you are with wanting to cut back. Okay, so when we think about treatment, alcohol use disorder treatment should be offered early, often, and across the spectrum of liver disease. So I think this is really an important point. We think about two major kind of buckets or categories of treatment. We have behavioral treatment and we have medications. Behavioral treatments include things like brief interventions, and brief interventions are very focused, brief, less than 5 minutes, discussions that you can have one-on-one with a patient to help increase their awareness around the amount that they're drinking and try to motivate patients to develop a change plan. Now, brief interventions are the one thing all of us should have awareness around, because they can be done by a variety of different providers in our practices. You don't have to be a behavioral health provider. You don't have to be a doctor or an NP or a PA to do it. And they are effective, particularly for mild alcohol use disorder, in up to 10% of cases. Then we have other behavioral therapies, including cognitive behavioral therapy, motivational enhancement therapy, facilitation, peer support, community reinforcement, and couples therapy. And these typically, work in kind of different parts of the pathway of either getting patients to engage around treatment or identifying triggers and retraining kind of behaviors around alcohol, and typically happen over, several sessions. And then there are medications, and we think about medications, there's FDA approved medications, and then there are what we call second line treatments. So they're not FDA approved, but they are in guidelines, and I will touch on those today. Okay, and what we have here is levels of substance use disorder treatment. So we just talked about all of those behavioral therapy options, but we know that, prevention, early intervention is really where we talk about, screening and brief interventions. And then when we diagnose patients, then we think about outpatient as your kind of lowest level of treatment in terms of intensity. And that can be one-on-one or group therapy or peer support. Then you have level two, or what we call intensive outpatient. So we always think about stepping up care if patients start an outpatient treatment and are not at their goals in terms of where they want to be with alcohol. Then we want to think about, do they need to step up to more intense treatment? Intensive outpatient treatment is typically several times a week, 3 to 5 hours a day. Most of it is group therapy with some one-on-one therapy. And then we have what we call residential inpatient treatment. And then we also have kind of medically managed intensive inpatient treatment as well. Okay, a few words about medications. When we think about alcohol-related liver disease, the treatment really hinges on treatment for alcohol use disorder. So if I'm a patient and I want to think about medication options, the way I always try to frame it is about thinking about first-line options first. So these are FDA-approved treatment options for alcohol use disorder. What we know is that the one that almost everybody has awareness around when I meet them in our alcohol-related liver disease program is actually disulfiram, and that's the one I tell them I will never prescribe them if they have liver disease because it's contraindicated because of a risk of hepatotoxicity. But there are two other options, and that includes naltrexone. And naltrexone can be given as a once daily or IM monthly injection. It blocks the opioid receptor. It reduces heavy drinking days and cravings, improves abstinence, comes in a convenient dosing. It is contraindicated in patients with opioid use and metabolized by the liver. Some key points is that I think a lot of people are not aware that naltrexone, when it was first approved many years ago, had a black box warning to use in caution with patients with liver disease. And that's because it was studied in patients with active alcohol use. So patients were studied by either giving them placebo or naltrexone among active alcohol users. And what they saw was that there was some liver test elevations in both groups. And so this black box warning was placed, but then it actually was removed over 10 years ago in 2013 because the FDA realized it couldn't disentangle how much of the liver test elevations were actually from drinking versus the medication. And then there have been now several large retrospective and other studies that show that the risk of liver toxicity is really negligible and low with naltrexone. So much so that the NIH Liver Tox, so that's a drug-induced liver injury resource that the NIH has created, states that most serum aminotransferase elevations with naltrexone are mild and self-limiting, resolving with continuation of therapy. In the trials, the liver test elevations occurred between weeks, 3 and 8. So an easy thing to do to reassure yourself and the patients is to just check liver tests 1 month after you start treatment. And like I said, there have been now several observational studies that show that patients are just more likely to live when they get a first-line option, including naltrexone. So I think it is a medication that should and can be used with shared decision making. The other medication that's first line is acamprosate. And the also improves abstinence and decreases cravings, and it works on neurotransmitters in the brain, although it is not really clear what the mechanism of action it is. It does require a patient to take it 3 times a day, and that is tough for a lot of people to do, to take a medications 3 times a day. And you cannot use it in patients with, a significant kidney injury, a GFR less than 30. And if you have a GFR between 30 and 60, you reduce it to 333 milligrams 3 times a day. So two first-line options to think about. Then we have second line options, and second line options include gabapentin. Okay, and so it's not approved by the FDA for alcohol use disorder, but they're in the American Psychiatric Association guidelines, as well as the VA Substance Use Disorder Department of Defense guidelines for alcohol use disorder. You can give it up to 3 times a day. It has been shown both gabapentin and topiramate work by way of the GABA receptors in the brain and reduces heavy drinking days and cravings and improves abstinence. And then topiramate is also a medication that can be given daily, reduces heavy drinking days and cravings, and has a convenient dosing. I don't use it in patients with advanced liver disease because of the risk of neurocognitive side effects. Oops, hold on. All right, so let's see. Okay, so I think one thing to recognize though is that AUD medications aren't complicated to prescribe. You actually don't need any specialized training. They're highly effective based on the number needed to treat. That's how we look at like the yardstick for effectiveness. But It's less than 2% of adults that receive medications for alcohol use disorder in the last year. And so there is this sense that alcohol use disorder is a different health issue, and it really does contribute to a lack of prescribing among providers. And I just mentioned number needed to treat shows that it is highly effective. So naltrexone to reduce heavy drinking days, the number needed to treat is 12. Acamprosate to prevent return to heavy drinking is 12. And, just to kind of juxtapose this in a way that might speak to a little bit of the issue is that antihypertensives, which is also in this table further down, is given for stroke prevention in up to 70% of patients. And yet we only have less than 2% with alcohol use disorder who are on treatment with medications for alcohol use disorder. So the other category I mentioned was behavioral health therapy or providers for alcohol use disorder. The MDHHS actually launched about a year and a half to 2 years now, this SUD locator tool. So it's a nice tool that pulls data from the LARA file of licensed substance use disorder service programs, and it gets updated quarterly. It's also combined with the certified community behavioral health clinics file and the health home providers inpatient health plan file. So it's supposed to be a more up-to-date resource than some of the national resources to identify providers based on zip code of your patients. So this is a nice tool to be aware of. There are no magic golden ticket kind of methods to getting patients to behavioral health providers. This piece can still feel very fragmented and siloed. And it's challenging. So I often describe it to patients, unfortunately, like looking for a job and having to call providers. You can call your insurance company to get a list of providers that are covered, but then it is going to take some work to get in. I wish it wasn't this way, but this is the biggest question we always get is like, what's the easy way to get somebody to behavioral therapy options? And I will just say it's not easy. Okay, there are some national resources, including the findtreatment.gov locator, the NIAAA Alcohol Treatment Navigator, which keeps a national resource of providers. And then I think the most practical way is to help build connections to substance use disorder providers in your community and among your network. And then having the patients call their insurance programs and email them a list of programs that might be covered under their insurance is always helpful. I spend a lot of time thinking about how we can diagnose alcohol-related liver disease before somebody becomes jaundice or has signs of liver failure. And what we know is that in a primary care population, it's a very small percentage, less than 3%, who will have alcohol-related liver disease. But among alcohol use disorder diagnosed patients, over 50% will have alcohol-related liver disease. So to me, a very logical kind of pathway is that in particularly primary care settings where USPSTF really encourages us to do screening for unhealthy alcohol use, among all your asymptomatic patients, if you do the audit C screen once a year, and then if that's positive, evaluate them for alcohol use disorder. Among those, think about screening them for liver disease, checking liver tests. If the liver tests are elevated, get an ultrasound to see if they have fat in their liver. But fat in their liver isn't just going to be the thing that gets into problems. It's going to be the patients who are developing fibrosis. And that's where we then leverage in the liver world non-invasive fibrosis assessments to try to figure out who is low fibrosis risk, where then the focus can really be just an alcohol use disorder treatment versus those who have actually significant liver fibrosis and would benefit from a multidisciplinary, alcohol-related liver disease or alcohol use disorder treatment program. And then the other way we get referred patients, particularly in the specialty space and GI and liver, is that somebody does have a liver test elevation. And I would argue among all of those patients who are coming into the door to our practices, we need to actually implement audit C screening to systematically identify patients with unhealthy alcohol use. If it's positive, evaluate them for alcohol use disorder, rule out other liver diseases, and then again, stratify patients based on liver fibrosis risk to understand where to focus care. And I think the thing to keep in mind is that the majority of alcohol-related liver disease is still diagnosed very late. And so thinking about how do we get to patients earlier is something I spend quite a bit of time thinking about. Now, we do have non-invasive ways for us to assess fibrosis in patients who have alcohol-related liver disease. The most simple test is the FIB-4. You don't need any specialty liver doctor to do that. It's just your age, your platelets, your AST, and your ALT. And then we have more sophisticated tests like the FibroScan or transient elastography and other proprietary tests like ELF and FibroTest. But these tests at different threshold can then help us rule in or out significant fibrosis in patients. And in more recent studies, it looks like these tools might actually help us predict who needs to stay with a liver doctor or come to a liver doctor versus who can stay in primary care and continue focus on alcohol use disorder care and treatment. So one thing that was actually really started at University of Michigan back in 2018 was this concept of multidisciplinary integrated alcohol-related liver disease and alcohol use disorder care. And what we know is that this model really evolved out of just seeing such a high demand for patients needing rescue options like liver transplant. And we know that many patients, if they reduce alcohol or even stop, they will have potential for regeneration recovery of their sick liver disease. And so we know that this model is now recommended for patients with very advanced liver disease, so with cirrhosis or alcohol-associated hepatitis. But I think there's still some unanswered questions, and these include things like how do we think about different models of care outside of transplant centers, which tend to be resource rich? Can we optimize models for different types of settings? What if you had just a general hepatology practice was one such question, which I'll show you some data on. And then given the increased demand, can we talk about how do we adapt and optimize these models to build them and make them more efficient? So this was a study that we're getting ready to publish now, and it was just looking in a general hepatology clinic in the VA if we integrated and co-located a licensed clinical social worker, so a behavioral health provider, and worked on identifying liver patients seen in general hepatology who might have alcohol-related needs. What would co-locating and referring patients to this co-located social worker do? So over the year of January 2023 to January 2024, we saw over close to 1,500 patients, unique patients. One-fifth of these patients in a general hepatology patient setting had unhealthy alcohol use, so they had a positive audit C screen. They were diagnosed with alcohol use disorder and were still drinking, or had cirrhosis and were drinking alcohol. What we found was that only 24%, so this is a problem we're now working through, of providers referred their patients to the social worker. So some of that might have been how it was offered, how it was discussed with the patient, or patients not knowing about like the full depth of services the social worker might have had. So about a quarter of patients got referred, and among those that got referred, they were more likely to get engaged in treatment for alcohol use disorder. So they got more psychotherapy, they got more medication, fill days. And so co-locating a behavioral health provider, even in a general hepatology practice, might have its benefits. Some other things that we have now started to see in our field is can we leverage tools in the liver space in patients who have unhealthy alcohol use to give them some personalized feedback around whether or not they do have alcohol-related liver disease, and if so, what stage is it in? And can we do that test and couple it with a brief intervention, a counseling intervention, to see if that then changes alcohol behavior? So this is across a lot of different studies, meta-analysis published that over 20 studies, including 16 randomized controlled trials, that there was this method of giving patients personalized liver biofeedback if they have unhealthy alcohol use led to a 36% reduction in self-reported alcohol use. Okay. And so the test we now have is this FibroScan test that's fairly readily available in specialty practices. So can we work with primary care colleagues to leverage this test to say, hey, you have fatty liver and you're drinking unhealthy alcohol. What do you think about this? And, this is what's at risk. You're at risk to develop more significant fibrosis. And in this setting, talk about setting goals and navigating patients who might be interested in treatment if they feel like they can't achieve their goals on their own. So I'll just end by kind of going back to the case. After shared decision making, the patient decides to start naltrexone, 50 milligrams daily, and engages in one-to-one cognitive behavioral therapy in the community. She's being monitored with serial direct alcohol biomarkers, the PEth test. Her liver function improved, and she's maintained alcohol abstinence. I do a repeat transient elastography FibroScan test 6 months after alcohol abstinent confirms that she has cirrhosis. So she's going to be monitored in our interdisciplinary AUD ALD clinic and will undergo liver cancer surveillance lifelong and variceal screening. So I guess I'll just end with some key takeaways here is that we have evidence-based alcohol use disorder treatments, and most people recover or markedly improve if they decrease alcohol use with treatment, and that can result in really remarkable recovery of the liver function. Alcohol use disorder pharmacotherapy has a very high efficacy in terms of the number needed to treat compared to other commonly prescribed medications. It's no more complicated to prescribe or monitor these medications than for other common medical conditions. So I think it's really up to us as providers and systems to talk about how we offer it and discuss it more with our patients as part of the treatment paradigm. Alcohol-related liver disease treatment really hinges on alcohol use disorder treatment. And I will just like really put in a plug that naltrexone is safe and effective in alcohol-related liver disease. Don't withhold it, talk about it, offer it to your patients, because it will lead to patients living longer. So
So we did have a question come in. So it's a question regarding the follow-up of behavioral health assessment with a positive audit C. Would this provider be a counselor, licensed social worker, mental health MP, or a psychiatrist?
sorry, can you repeat that first part of the question?
Yeah, so it was regarding the follow-up behavioral health assessment with a positive audit C.
So, yeah, so typically you want to do first deliver a brief counseling intervention, right? And then for some patients, that might be enough, particularly those who have um, unhealthy alcohol use that either might not meet criteria for alcohol use disorder or if they have mild alcohol use disorder. Now, how do you tease that out with the audit C, right? So a score of 5 and higher on a scale of 0 to 12 is a positive screen. 5 to 7 typically maps to a mild alcohol use disorder. 8 to 12 typically maps to a moderate to severe alcohol use disorder. So the first thing you do is you start with the brief counseling intervention. And then if you really do want to work towards making the diagnosis, if you're in a system that has the checklist approach, you could do that as a first step or refer them to a behavioral health provider. Just know that a lot of patients won't go to see a behavioral health provider because there's a lot of stigma about going to see behavioral health providers to get that evaluation. So I think now we're seeing more and more at systems like Michigan Medicine. We now have behavioral health collaborative care, which actually was born out of the VA system. So in the collaborative care model, they have behavioral health providers that are integrated into primary care, right? So you're bringing behavioral health to patients, especially in a space where maybe primary care providers are just too busy managing too many other things. And so in our system and the VA system and many other systems now that are leveraging these models, someone will administer the screen's positive, then the behavioral health provider in the primary care setting reaches out to the patient. And I do think that that's an optimal model because it's using kind of like, these measurement-based care approaches. So like you may start with the screening assessment. Once then that behavioral health provider can help them make the diagnosis or get them to somebody to make the diagnosis of alcohol use disorder. And then other things like BAM and other assessments can be used with the support of a psychiatrist in the background. The collaborative care model is really meant to build primary care capacity. So in that model, it's even used for like depression and anxiety. It's led to, for example, in the VA, faster medication starts for depression because it's done in primary care where most of these patients are located. And it then gets the primary care doctor to prescribe the medication that's recommended.
And a follow-up to that. So should that assessment be same day during after the PCP visit or in a follow-up visit? And does it need to be face-to-face?
Yeah, I think a lot of things are really up for adaptation. There's no right or wrong. I personally think it's most helpful. I think a couple of take-home points. Screening shouldn't be done in the absence of setting up the following steps, the follow-up steps that are needed, right? And the follow-up steps and that's clearly laid out in USPSTF guidelines. If you're going to do the screening, if they screen positive, the minimum you have to do is the brief counseling intervention. But remember, anybody can do a brief counseling intervention. Your nurses can do it. Your patient care associates could be trained to do it. Your providers can do it. And that is just a brief, focused discussion around alcohol, alcohol-related harms, and whether or not the patient wants to come up with a change plan. So those things have to happen. So if you do the screening, you have to be prepared to act on it. And then if that screen is positive, then ideally you are evaluating them, or you're getting them to somebody who can evaluate them for alcohol use disorder. Just doing the first step without the second step is like begets the question of like, why are we doing it? And that's the whole paradigm of screening, brief intervention, referral to treatment, which is an evidence-based, really continuum, right, model of care. So it doesn't stop with just screening and asking them how much they're drinking, but then you're acting on it and then moving patients who are still drinking in an unhealthy amount towards treatment. Does that make sense? And
For the
so
next,
in terms of virtual, one thing I will say about the Audit C screening, because the VA has studied this pretty extensively, the VA implemented Audit C annually for all veterans in the entire VHA system back in 2003 and 2004 with the help of giants in the field like Catherine Bradley and many others, okay? And they do it in 90% of veterans in primary care annually. So it's done robustly and it's been done for a long time. What they did find was that when the questions are administered to them by a medical professional, they're less likely to answer as honestly. So what they did was they administered it in the office, but then they sent patients a survey home too. The survey results showed that like 10% were underreporting when they were asked in person. So for that reason, we now have these electronic health records. We have assessments built in, for example, at Michigan Medicine and other places where we can send the Audit C in the VA, we can send the Audit C to the patients ahead of their appointments so that we send them out on Fridays if they're coming in on Mondays, or we send them out a week before, and then we get the response so we can act on it when they come to clinic. And then the rest of the evaluation, virtual care is here. So meeting with the behavioral health provider in person or virtually is really, I think, up to the patient and finding out what they might prefer and what they might engage in better.
okay. And we did have someone with a raised hand. Dawn, you should be able to go ahead and ask your question.
I just wanted to make a comment to any of the health professionals that are here. You have a couple of peer recovery coaches here today who are here to learn. And so I just wanted to mention the value of peer recovery coaches actually performing the SBIRT and the audit, because people are more inclined to talk to someone who's actually got lived experience. So I work in a hospital setting, so does my partner. And the SBIRT should be implemented in all healthcare settings. Thank you.
Good point. I like that point. Thanks, Don.
Do you have any data available to share that is specific to LGBTQ plus communities?
I think for the focus of this talk, I didn't. There are definitely communities that are affected and impacted differentially in this space. We know we're actually doing a lot of work with Native American communities across the state and talking about, how to implement and talk about alcohol and bring tribal best practices with evidence-based practices. So I didn't have that for the focus of this talk. There are SAMHSA and NIAAA may have some additional data and resources at their websites. And Katrina, maybe we can get those to folks after this meeting.
We can look into sending that. And then Tanya, you should be unmuted and go ahead and ask your question.
Oh, hello. I just wanted to ask a question in regards to the naltrexone. There is not only the injection, but the oral medication, right? Do you have a preference for one or the other?
Yeah, so I love intramuscular naltrexone. It's just so painful to get it approved by insurance companies, which is just a travesty in my opinion. We've set up a whole pathway in our clinic to access it, but where we have the highest failure rate is with the prior authorization piece. We are looking into like if there are certain things we can learn, like we did with Hep C approvals and other things, because we have a lot of experience with prior authorizations and approvals. So this is just like a not good thing on the part of the insurance companies, making it hard to access it. So I think for patients who have and struggle with adherence to medications, the IM formulation is great. Now, the IM formulation of the 380 micrograms IM, it's an intragluteal injection. So it becomes hard to do it at, like we've talked about, can we get it at CVS and, Costco and Sam's, like local, like clinics, right, that have minute clinics. But it does require, some privacy, like a setting in which you can be privately administered because it's not in the arm. It's intragluteal. And it does have this prior authorization piece to it. So that's just the biggest holdup. Now, the other piece I'll say is that the dose maps a little bit better to the 50 milligram dose rather than the 100 milligram dose. So if I have a patient who I might start on PO naltrexone and then I'm trying to get the IM approved, and then I find that they have reduced cravings and we try the 100 milligrams dosing and that works better for the patient, then sometimes I'll have a discussion about trying to stay on the PO because it's going to give them a higher dose than what the IM does. There is no IM formulation for the higher dose of naltrexone that I'm aware of.
Thank you.
And then the next person, you should be unmuted and go ahead and ask your question. All right. Well, we'll go to the next question, and then if they get unmuted, they can go ahead and ask their question. Is there any evidence of long-term recovery once naltrexone has been discontinued?
Say, repeat that again. Not long-term recovery?
Yeah. Is there any evidence of long-term recovery once naltrexone has been discontinued?
Yeah, we see it all the time. I mean, I think there's no prescribed length or duration of treatment with naltrexone or for alcohol use disorder in general. There's no guidance that says everybody should get 3 months or 6 months. In the context of liver disease, the patients I see who tend to have signs of liver failure or portal hypertension, a big motivational factor for stopping alcohol use is they get too sick. They feel too sick. They know that continuing to drink will continue to make them feel ill, and especially if they're in and out of the hospital. So for them, we just talked about regeneration and recovery and recompensation of the liver disease. For them, the most vulnerable time is actually the first 6 months as they're recouping or stabilizing their liver function as they feel better. And as they feel better, that's the time where, particularly in those patients with liver disease, the time is the highest for relapse. And so for a lot of our patients, we'll say, let's start, if you want to start this and you're doing well on it, let's just continue it for the first 6 months. Now, we'll also try to understand what the other triggers are, though, because cravings and urges can be helpful, like curbing that can be helpful, and treatment in and of itself and medications alone are highly effective for some patients. But for other patients, if it's tied to other triggers, right? If it's trauma, if it's other mental health disorders, if it's other stressors in their life, then the behavioral therapy piece is what might actually be also adjunctively helpful. So some people do really well with just medications, with just therapy, and some patients do really well with a combination of the two. So the approach I try to take is, one, I always want to understand what a patient's already tried, and then talk about whether or not they're open to retrying things. Sometimes people are in a different mindset. They're drinking when they take their naltrexone, so then disentangling how much of like their nausea that they had was from drinking versus the naltrexone in the past can be hard. So we'll talk about retrialing and or trying something different. And when you think about the different combinations of thing, if it's peer support recovery, if it's AA smart recovery in the room combined with naltrexone or one-on-one therapy or group therapy, that's where like the potential to think about how do you really tailor the treatment to what a patient's interested in and what might work. And so in that framework, I find that we have a lot of things we could discuss with patients.
Okay, thank you so much, Dr. Perumalswamy. And with that, we are at time. So thank you again to everyone for joining us. If you did not get the continuing education credit information, that will be sent out in an email. And I hope everyone has a great rest of their day.